Good afternoon, everybody. Thank you for joining us. Um, I just, I want to thank everyone for coming and registering for this webinar. My name is David Minot, and I'm the Executive Director at Mental Health News Education, the nonprofit organization that publishes autism spectrum news and behavioral health news. Behavioral Health News was founded in 1999 and provides a trusted source of science-based education, information, advocacy, and community resources on mental illness and substance use disorders to consumers, families, and the professional community. I encourage you to check out the websites of both of our publications at behavioralhealthnews.org and autismspectrumnews.org, where you will find over 2,000 educational articles made freely available to you to read and share. And if you wish to contact me, please email dminot@mhnews.org. Today, we are presenting This Will Only Hurt a Little, Stoicism in the Face of EHR Implementations, presented by Jawad Sartaj and Terence Russo. Jawad is the founder and CEO of Informed, a trusted advisor and counselor to community-based organizations. Their expertise lies in strategic EHR and population health platform implementations. For more information, visit informed.ai. Terence Russo is partner and director with Garfunkel Wild, a full-service law firm providing assistance to a broad range of clients, including hospitals, healthcare systems, and other healthcare facilities, organizations, practitioners, and technology companies. Garfunkel Wild's Information Technology and Data Practice Group is a leader in providing legal services to healthcare providers, professionals, technology companies, and businesses in connection with technology matters. For more information, visit garfunkelwild.com. Just a little housekeeping before we get started. We will be recording this webinar and it will be available on the Behavioral Health News website in a few days, along with a copy of this presentation. Throughout this webinar, attendees will be in listen-only mode. The presentation will be about 35 minutes or so, with about 15 minutes reserved at the end for questions and answers. If you have any questions during the presentation, you can submit them by clicking on the Q&A icon located at the bottom of your screen. With that, I am happy to turn it over to Jawad.
David, thank you. Good afternoon, everyone. This is typically the part in the conversation where you might expect me to tell you about how many organizations we support, how many EHRs we've implemented, or the number of vulnerable lives that we've brought together through our population health implementations. We're not going to do that. We're not going to bore you with that. And instead, as David mentioned, we're most excited about answering your real questions. So I'm going to jump right into our presentation and preserve as much time as we can for that Q&A. Before we go deeper, I want to level set. It's really important to know that there are no villains in this story. We believe what you're going to hear from us, from Terence and I, in the dichotomy of practices and providers and their corresponding EHR partners, is the result of unmet needs, a shifting landscape, misunderstandings and expectation, and ultimately misalignment, not a story of the good guys versus the bad guys. So with that, this is the first in a series of conversations we hope to have with the community. And we've titled this appropriately, This Will Only Hurt a Little. And we chose this because far too often promises are made to you as providers of painless implementations from vendors and consultants alike. I know of several organizations that do incredible things with their EHR, and no one, from the executive director down to the frontline staff, has ever referred to their EHR implementation as painless. So we believe that perpetuating the myth of turnkey, 6-month-long, painless implementations does more harm than good. What's occurred over the last few years is EHRs have gone from one platform to rule them all. where they were central to the success of practice, with vendors, EHR vendors, being held accountable to deliver grand results, but without the authority to get it done. And often the conversation was one way: conform your product vendor to meet the needs of my agency, my practice, and my process. And in return, vendors began to craft bespoke implementations. It became the Burger King way, have it your way, which becomes unwieldy, expensive, and ultimately unsustainable unless you're an organization with deep pockets. In the last few years, two major events have shifted that landscapes and made EHRs more accessible to organizations with slimmer budgets. The first is the evolution of software as a service. You no longer have to stand up an entire expensive infrastructure, a data center, and all the trappings that come with that to get into the game. You just need an internet connection. And second, the vendor's desires to mitigate their risk by decoupling installation from implementation. That is to say, you'll often find vendors will provision an instance of their software for your agency, train some of your folks, and call that an activation. We've gone quickly in the last few years from chauffeurs to more of an Uber model. And while that change does create access, it's not without angst. We see that angst mostly expressed as cynicism in the minds of executive directors who are contemplating an EHR or who are either contemplating a new EHR or leaving their existing vendor, but find great divergence between what's shown at conferences as the art of the possible and what their peers are telling them over coffee in confidence. We see that angst reflected in the number of organizations that approach us for transitional guidance despite having just implemented an EHR less than 36 months ago. And most of all, we see that angst exacerbating a staffing issue because your team members go from contributors to taking on full-time secondary responsibilities post-implementation. And that last point is very dangerous during this great resignation period, where billions of dollars are being poured into digital health startups who are clamoring for the same resources that you have on your payroll, but with a much larger war chest. All that is to say is we're starting to see trust erode between healthcare organizations and the software partners who seek to support them, to the point that about 3 weeks ago, I had an agency head tell me that she thought it was better to stay on paper. Imagine someone telling you in 2021 that they preferred a rotary phone to an iPhone. And you get a sense of that dynamic. Terence, how have you seen this dynamic play out on your end?
Sure, Jawad. Unfortunately, I've seen some bad implementations, and bad implementations can be expensive and frustrating. And we're going to talk about ways to reduce that risk. I mean, change is scary, right? I think all therapists say that change is scary, and changing your EHR is also scary. The one or two takeaways for this slide that I would see as most important is communication. You know, just like marriage, you need communication between partners, between a healthcare provider and an EHR vendor. You need to have very good communication skills. There has to be a meeting of the minds on, you know, what you're going to receive, who's going to do what each party's responsibilities are, timelines, those type of things. When I start hearing, Jawad, art of the possible, I always get a little nervous. I like to get down to brass tacks so that there's no unpleasant surprises. You know, the general rule, caveat emptor, buyer beware, makes sense with an EHR. It's an important, critical piece of your practice. And so You have to make sure you, the healthcare provider, are communicating well with the EHR vendor, and the EHR vendor is communicating back to the provider so that there are no surprises. So that's one thing, key communication, and we'll talk about that later in terms of a detailed implementation work plan and key deliverables and getting the incentives aligned. The second point I'd like to talk about is just, you mentioned this earlier, that there's a change in implementations. In the old days, you had to buy $100,000 worth of equipment, set it up on your own servers and data centers. Now, there's a different, the SaaS model, the cloud only model, and sometimes the vendor will click it on and say you're ready to go, but it's not really useful yet. So especially if there's a balance, there's the one size fits all model, which is great if it works for you, but unfortunately you often have to customize your product. You have some integrations. Each practice has its unique workflow, so you have to keep that in mind. The other option is have it your way. Let's customize it, and you'll get everything that every quirky workflow that you have will address. There's a cost to that. It's expensive, and things can go wrong when you do that. So you have to have a balance. Some customization is generally necessary, but I remember in the old days, it was always best in class, best in class, best in class, and you had healthcare providers with a hodgepodge of different systems, different billing systems, registration, scheduling, clinical notes. Now it's more all-in-one. I want an all-in-one solution because I don't want to deal with all those integrations. And likewise, similarly, when you're doing an implementation, you have to think through how much customization do I need? And the general rule is, to the extent you can make less customization and work within the vendor's workflows, you're going to have less problems with implementation.
So it sounds like the art of the possible has to meet the art of the practical.
Definitely. And let's get specific. Specifics are how you avoid problems down the road.
And so if we can't minimize pain, the landscape's changing, miscommunications veering towards mistrust, how do we move forward? How do you folks at practices take advantage of this technology, or is the answer to return to paper? We don't believe in that. We believe there is value to the EHR. We believe there is a great deal of benefit when an EHR implementation is done right. We've worked with IPAs that have been able to stratify high-risk lives by bringing the right data into their EHR and asking the right questions of their data. We've led implementations for a behavioral health collaborative, which made the referral process for their sister agencies and their SDOH partners frictionless. And we supported a small agency that was able to navigate extraordinary complex billing rules, but still have a 98% capture rate. And all of that is only possible with the right EHR. So what do successful implementations all have in common? We believe that the highest level of success comes when agencies and vendors align in three ways, in the three ways that matter: strategically, tactically, and contractually. When both parties agree to a vision, jointly embrace pain, and seek to minimize risk, that's when both parties agree to a journey of practice transformation, not software implementation. Now, let me explain why that's so important. Most agencies seeking to either go to a new EHR or migrate away from their old one begin by asking potential vendors to do all the things that the old vendor could not do. And if during a demo, one of the vendors has a high degree of competency in your needs, they often find themselves the recipient of the contract. We believe that's only half the story. Those unmet needs, the deficiencies of the old system, only account for today's needs. They don't envision or envisage future growth. And they certainly don't account for the areas that aren't under scrutiny. What happens when you, as the chief program officer for a behavioral health organization, knee deep in trying to submit a SAMHSA grant to become a CCBHC, find that the most common housing status for your lives is not applicable? What happens when you're a primary care organization thinking about partnering with the large physicians association, thinking about entering into risk-based contracts, but you have no idea which patients to contact because there's a stark difference between what the payer considers as members without visit and what your EHR says? Who wins? What happens when your credentialing team improperly codes taxonomy codes, not knowing how they interweave with billing, and you leave $600,000 on the table in funding that year? What happens when you're the CEO of a for-profit organization trying to show your primary payer the efficacy of your whole person care model, but you have no data to tell that story? All four of those are real-world examples of agencies that have struggled after spending small fortunes. And these are the kind of issues that, again, ultimately fester and turn into breaking points. And once again, you find yourself wanting to move vendors less than 3 years after you got the last one. And so without deep contemplation, a full perspective of needs, agencies again find themselves having to spend either unplanned dollars or worse, grit their teeth and do without. And you find yourself printing paper and taping it together to look at your daily census, your show rate, and your AR. Again, real life examples. Or you have your front registration person is the stopgap for all AR activities, for all show rates, for everything. You try to address all of that up front, and it just becomes unsustainable. Terence, can you share some experiences on how some of those unmet needs that I've described may make themselves aware to you from a legal perspective? Folks call your office and say, oh my God, or is it all roses and rainbows?
I wish. Unfortunately, yes, it happens too often, where the healthcare provider didn't realize exactly what they were getting or what they weren't getting. And, the devil's in the details. One thing I often tell, this is kind of the autopsy of a bad implementation, the things that I see that maybe the providers should have done just to keep both parties happy, the vendors and the providers. Don't rely on the demo. The demo is not enough. An RFP, even if you do a formal request for proposal, that's generally not enough either. You need to have a lot of conversations. I'm always shocked at how many times healthcare providers haven't seen the user manual or the documentation. That's the basic warranty you get in a contract. You receive in a contract. It says the software will do what the user manual says it will do. And a lot of times I've had clients call me up after the fact when they don't have a key report or they don't have some type of integration that they needed. And it's clearly spelled out in the documentation that that's not a functionality. Sometimes they tell me, my clients say, yeah, but I was told it was going to come in the next version. It was coming soon. We call that vaporware. It's very hard to rely on future products. That's always a risk. So I would always advise my clients, look at your documentation, ask for it. Ask for the user manual, because that's the #1 performance warranty any contract has. And I'm always shocked that a lot of clients don't even look at it. So that's one thing. Second thing I would advise, just to avoid the unpleasant, buyer's remorse. And it's not always the vendor's fault. It's often there just wasn't good communication. But you need to contractually define a successful implementation in writing. And if it's not in the contract, you don't have anything. It's not intended to say, a vendor is selling you something they don't have. That's not what it's about. It's memories are different, communications, people are misunderstanding each other. Memories are faulty. Oftentimes when there's a dispute, it's a different team than the sales team that sold you the product. So you have to have it in the contract. There's a general, I would say 99% of all contracts, especially EHR contracts, have a provision called a merger clause, which just basically says only the terms in the contract apply. If there were PowerPoints, decks, presentations, emails, even in writing from the vendor, that's null and void. You can't rely on it. Everything is spelled out in the contract. So just realize, it shouldn't. It's not a handshake type deal. Some things are a handshake deal. This is not a handshake deal. You should specify in the contract what is success. And one of the ideas is to have a written implementation work plan. I generally see the more detailed and thought out the implementation work plan is, the better, the less likely there'll be a problem down the road, Jawad. If sometimes you can't always get the implementation work plan to be filled out and completed before you sign the contract because the vendor doesn't want to expend all those resources, but you can get a high level plan, or you have a commitment that you'll mutually agree on it. Both parties have to agree on it, a written plan within 30 days or whatever the time frame is. And work plans evolve, but you should get the framework in. Otherwise, you might be heading in different directions, and that isn't good for anyone. Lastly, this doesn't really the format for it here, but every contract should have certain basic warranties to avoid the horrible case where you purchase a system and it doesn't have a key report that you need. It doesn't capture certain data that you need. It doesn't have interoperability with something that you need. Compliance with law, compliance with payer requirements, reporting spelled out. Those things should all be spelled out in the contract, which, if you do it up front, if you put the effort in earlier, you won't pay for it later. I mean, it's much more messy, Jawad, when I'm brought in after the contract's signed, 6 months into an implementation that's going south, and I got to bring my litigators in. It's just a mess. So, put the effort in early and make sure that both parties are on the same page in writing.
We find ourselves, Terence, you and I commiserating often about having to put the yolk back into the egg after the fact. We've seen 3-page contracts when they come to you turn into 30-page covenants. And I think part of the value proposition is both in contemplation of need and in contracting. You spoke of things gone awry. Any other thoughts relative to entering a new EHR relationship? Any thoughts on project plans? I know you mentioned about having deep detail. Any other guidance that you would offer?
Sure. Thinking of the most common problems or pitfalls, implementation plans should include interfaces or customization that should be spelled out in detail to the extent you can. I've seen things that are called implementation plans, but I would call them a high-level catalog of ideas. That's not an implementation. So the more detail, the better. That's the general rule. But there are one or two other ideas. One, if you don't have the in-house resources, the technical expertise, even when the vendor is doing most of the work, you still have to line up your training. You're still going to need somebody on your side, some consultant project manager who's fluent with the operations and the technical functions involved on your side. It's not a bad. You started off. It's not a villains versus good guys, and I agree with you. But you can't have if you just have the project manager that's just on the other side, on the EHR vendor side. It's kind of like the fox guard in the hen house. I mean, you need somebody to make sure that they're not just doing what's easier for them, and it's actually going to meet the provider's needs. So that's one thing I would often recommend. If you don't have the expertise, invest in that. The last thing, I think we might talk about it later on, Jawad, if we have time, but I am a cynical lawyer by nature. I generally tie the money. I like to hold the money as long as possible. I like to tie fees to milestones. You know, once we hit go live, once this percentage of the workforce is trained, once the data has been migrated and tested, once there's been, you know, a couple of days to test the functionalities and the customer can sign off. If you hold the fees until certain milestones, implementation milestones, especially acceptance date, you avoid the activation where the vendor thinks it's ready to go and the provider isn't really ready to do anything. You avoid that situation, and you really avoid fights down the road. You have everybody's incentives aligned to get to an implementation where the customer and the vendor both say it's ready to go. So if you do that, that's kind of the aligning incentives part. Don't just pay. I'll start paying everything, you know, 90 days after signing, because if the implementation goes south and it gets delayed, which often happens, you know, as the provider, you're out of luck. You're paying for something and you don't really have anything for it. So those are kind of big ticket items to think about when you're reviewing a contract or getting ready for some type of new EHR solution.
And that last point you made, Terence, relative to acceptance, oftentimes availability is what the vendor denotes as successful implementation. Availability of system is not is a far cry from utilization of system. And so just to have that clearly spelled out, where you're no longer, you know, 6 months after contracting or 9 months after contracting, whatever time after contracting, you're not sitting there saying, well, from our perspective, this is complete. And you're like, wait a minute, I've got this outstanding, this outstanding, this outstanding. I imagine you've seen that play out, which is why you're espousing this very concrete implementation plan, meeting of the minds, and then concretize that with, this is what we're saying is a payment trigger.
That's right. Availability, access, activation, all the dates. You have to kind of read the definitions to make sure what the vendor considers handoff is the same thing as what the customer considers handoff. And that is there's often not a meeting of minds on that, and that leads to problems down the road and hidden costs. And all of a sudden, there goes your budget. You know, it's not a good thing.
12 months of runway expended in 3 is never a good thing. So let's recap. You find yourself in a situation where you're unhappy with your existing vendor. You're trying to seek out a new partnership. You want to orient that relationship towards mutual success in the ways that you've heard from Terence and I. You might employ some of these strategies. And so you're likely to call up 3 or 4 vendors that operate in the space that you work in. And you tell them you no longer want a software implementation, but you want practice transformation. How do you think that's going to look like? Well, I imagine you're going to get back a bunch of buzzwords. Foundationally, EHR vendors are software companies, and they operate from the lens of a technologist. So it's not uncommon for them to interpret practice transformation as digital transformation. Again, innocent mistake, a misunderstanding of expectations, but yet another opportunity for things to go askew if they're not managed properly. And much of the current conversation around digital transformation is fixated on analytics. Again, back to the art of the possible. And as a practitioner, I can tell you those technologies are still in their nascent stages. They have certainly not been integrated into EHRs in any meaningful way. And before I'm accused of being biased, let me speak from a place of evidence. This slide might be difficult to see. It's busy, but ultimately what it does is convey that there are 23 FDA-approved algorithms for use in clinical applications. The vast majority of them are imaging, radiology, cardiology, and that makes sense because foundationally, analytics is about pattern matching and anomaly detection. So unless you're buying a pack system, if you're getting messaging from your EHR vendor that they have the newest algorithms, and sometimes they'll say algo, which drives me nuts, but if you hear those words, if you hear words like algorithms, machine learning, natural language processing, if you start hearing those kinds of buzzwords, I suggest you ask them to be concrete in how they are actually using those technologies. What are they licensing? What are they ultimately providing in their software that really meets those needs? I suspect you will get a rather long answer that may not meet your needs. And so instead of focusing on AI, we suggest that you focus on the boring stuff. And what do we mean? What do we mean by the boring stuff? We mean decision support and revenue capture. In our experience, these two areas have the most importance for every organization that we worked with, from community-based organizations to large healthcare system. I recognize these are not fancy buzzwords. They're unlikely to get you on the front page of behavioral health news, and your success won't be touted in Wired magazine. But I assure you, from clients who have experienced these transformative shifts in the ways of decision support and revenue enhancement, that they will fundamentally transform your agency. You'll have the right information in the right hands at the right time while maximizing revenue. What does decision support look like? It's not simply reports. It's about extending that capability down to having your needs being answered by having access to your data. Most EHR vendors will want to have you create bespoke reporting or provide a set of canned reportings. We say go further. Have access to an enterprise data mart or data warehouse. Have all your data codified and be available to you, because ultimately you want to merge that data and leverage that data with other core systems, be it your ERP, be it your productivity, be it your payroll. All these other systems don't natively integrate, and it's costly to integrate them. So as you're looking to take that information out and avoid having to tape pieces of paper together, you're able to integrate all of that information in a meaningful way. Decision support does not just stop at reporting. It extends to answering pertinent questions for your business. Again, show rate, adherence, sentinel events, all of the things that matter to your practice all go under the bucket of decision support. And revenue enhancement is not just simply billing. It's an entire perspective of all the financial implications. I keep going back to show rate because it's my favorite one to demonstrate, and it's my favorite one to resolve, because everything from slot management to appointment, 3 weeks out appointments generally tend to have a 50% impact on show rates. So if we get your appointment times down, we can impact your show rate. All of that to me is part of revenue enhancement and integrity, and the interplay between revenue enhancement and decision support. So we would offer the right team, a strategic thought partner, someone to help you contemplate needs and craft a way forward, the right legal partner to help ensure your needs are in black and white, and the best fit EHR partner, all working together, walking in lockstep with you and aligning towards the same goal of practice transformation. Working with the same figure is where the magic happens, not in analytics and AIs and demos. So this will sound cheesy. How is it going to be painless? No. Will it hurt? With the right partners a little bit, but it'll be worthy pain. Terence, any final thoughts before we turn it over to the audience for questions?
Sure, I have one or two takeaways. One, I couldn't agree with you more, Jawad, on, the buzzwords. Um, I've, I'm getting a lot of contracts for AI and machine learning. Very few of them are really machine learning. What I have done, if you ever do pursue that, I do think decision support, revenue enhancement, the tried and true, the basic functionalities are most important. Sometimes you might be interested in some of these AI things. If you do, tie it to outcomes, because the few times I've negotiated these, it's, whether it's truly machine learning or not, I don't care. What my client wants is to see what's the outcome, what's the deliverable. And if you tie fees to deliverables, and I've done that in all sorts of interesting situations, even HR, AI is making hiring decisions, kind of scary, almost like the Matrix, but this Harvard trained computer scientist who worked under the Obama administration swore by it. And when he put 2/3 of his fees up, saying that we would reduce our nurse turnover rate and keep our retention up by 20%, which would save us a couple $100,000. Yeah, we tried it, but generally AI is be very leery about it. The last couple of items, just takeaways, and I do want to get some questions in here, was, look, we've seen good implementation and bad implementations, just like good and bad marriages. And you need to have good communication skills with your EHR partner. And those communications need to be spelled out in writing. Those are takes. Good sign. Some of the good signs I've seen, I can almost tell sometimes when I think it's a good implementation or bad, just by seeing the documents before I even speak with the client. If I see there is a detailed work plan, a specific timetable, responsibilities of both parties allocated, lots of time for training and testing, and I see a payment plan that is tied to milestones to get the vendor and the customer and the provider rowing together. Those are all great signs. Nothing is risk free. Crossing the street has some risk. There's always risk, but those are good signs. The bad signs, if I see lack of warranties, I see anything saying it will be in the next release, if I see poorly defined responsibilities, or I see fees starting right after signing, those are indicia that you might have problems down the road. Not guaranteed that it by any means, but those are more likely to cause problems. So those are the key takeaways from my perspective, Jawad.
I think I'll step in now. Thank you, Jawad and Terence. This has been wonderful information. It's about time where we can go ahead and take some questions now. Just a reminder, if you haven't already asked a question, please do so by clicking on the Q&A icon located at the bottom of your screen. Our first question is, do vendors provide beta testing for EHR?
Do you want me to take this one, Jawad?
I have a perspective, but please go right ahead.
Sure. Vendors offer beta testing. The question is usually when you're a test case, you're getting it at a discount. That's the benefit. But you are kind of a guinea pig. I get nervous being a pilot. Pilot programs, beta contracts always make me nervous. Generally, you're getting the product as is, as available, no warranties, and there's no guarantee they're going to go ahead with that project. So you'd have to really balance the risk. There's greater risks. One of the first questions I ask when I'm brought into a negotiation and we're talking about all the integrations or interfaces, or if we're getting a new module, I just say, have you done this before? By this, I mean this particular, this type of functionality. And when I hear, no, this is the first time, but we're excited about it, I dread it because I don't want to be the first. Nobody wants to be the first. You want to be in the middle of the pack. So sure, sometimes usually there's a different type of contract, and it's very clear that beta products, you're generally being offered it as is. So you're taking it, it might not work, and if it doesn't work, so be it. So you'd have to make sure that the risk reward analysis is done and the reward is significant. That's my thought on it.
I agree, Terence. I think if you've been in a relationship with an EHR vendor for a number of years and a beta product is available to you for a particular enhancement, that makes sense. But to kind of your first step into a relationship in a beta trial where things aren't really germane and gelled, and because you're migrating from a lot of residue of pain to an environment that it's not probably well baked. I've seen those be structured as partnerships, and that makes sense where you're getting a discount, where you're getting some kind of value add for your participation in the beta. Another perspective on this, and maybe the questionnaire was referring to, do EHR vendors offer a trial? Maybe if that's what's being meant by beta. Generally, you could, once you structure a contract, get some probationary period, and that might be a trial period. But generally speaking, because those softwares have to be customized to your liking, you're going to ultimately be playing in a sanitary sandbox. So it's art of the possible, art of the theoretical, more so than it is, here is your environment for 3 months, take it for a test drive. If you don't like it, bring it back to us. That I've yet to see anyone spin up effort and customization to allow you then to disengage early on. So I wasn't sure if the questionnaire was oriented in that direction, but from both perspectives, I think.
That's right. Jawad, if the question was directed more towards a free trial period, then I haven't seen it much on EHR, and this is a really simple system. I've seen it for a bunch of other software solutions. And the one thing I would warn, usually a pilot period, it's no charge or nominal charge, and you have an out after 90 days, 180 days, fine. But just realize if you're putting real data in there, you still got to deal with data security. You can't just say it's a 90-day, I'm not putting any money in here.
Right.
There's still a lot of risk. So always think of, you have to understand where the data is, especially if it's in the cloud. Most of these test cases are in the cloud. So once your data is out there, it's on you. Your EHR provider might be responsible to some extent, but it's going to be your headache and your reputation. So think that through before you start a pilot.
And to that, the psychology here is oftentimes folks want an initial period of time as trial as an expression of mistrust. And so if you're having that kind of inner angst, it means the contemplation and the contracting wasn't done right. Because we've seen where if the other side is not delivering, you have opportunities to hold them accountable in the way that Terence described, milestone payments. So usually what I see angst expressed as is, well, if we're going to get into this for 90 days and at a very low cost and it works out great, then we'll continue with it. But as Terence described, you're putting real data in there, you're changing interfaces, you're adopting business process to all throw it away in 90 days. That's not really a value-added proposition from the perspective of the agency. You don't want to go through that effort and then disintegrate. You rather want to make sure that you've lined your ducks up first before you start shooting.
Great. We do have a comment, just that selecting a vendor without proper certification will impact, delay, or eliminate opportunities for interoperability. And also, don't forget your BAA.
Don't ever forget never leave home without your BAA.
BAA, and sometimes your participating provider agreement as well. So PPAs and BAAs are absolutely important. And in terms of certification and integration points, all valid points. Again, do you integrate with our lab partner? Do you integrate well with our healthcare transaction broker, right? How do you get data from our HIE? Are you natively connected to one or more HIEs? Do you expose APIs? How do you get data in? How does data come out of you, right? All those contemplation points should absolutely be part of your upfront strategy, because that's where those are the unknown crevices that sometimes create angst after the fact.
That's right. I mean, I have a couple of thoughts on that. So interoperability, thank goodness, the info blocking rule, federal law went into effect last year. EHR vendors are not supposed to be. It's a violation of federal law to try to block and prevent interoperability. So I think it's going to decrease. Interoperability is a key thing, but certification, just be careful. Like if I see SOC 2 certification data center, or I see high trust certified, that's great. Meaningful use certified, of course, you need that. Oh, that's great. When I start seeing vendors that say we're HIPAA certified, that doesn't mean anything to me. There is no organization that certifies really HIPAA. So, certified by who? It doesn't really, you have to be careful with certifications. I often, a few times when I've been involved with data breaches and the client tells me, well, the vendor was HIPAA certified, I always ask by who, because there is no agency. It doesn't really mean anything. And you find, oh, they paid somebody $100 to be certified. But anyway, but certifications in terms of, I always feel much safer from a data security perspective if I hear that the vendor's, high trust certified. I think that makes our job much easier because a lot of agencies probably don't have the resources to do a deep dive into the cybersecurity of their vendors. And yet, the truth is, if a vendor causes a breach, it's your problem as well. It's both your problems.
And Terence, to that point, SOC 2 at a bare minimum, if it's HIPAA certified in the sense that my cynicism is going to come out now. If you're self-certifying, which, Terence, we've seen that before, who's really certifying and what framework are you adopting, is your EHR adopting to ensure your data is not at risk? I think SOC 2 is a bare minimum. So you can get to high trust and FedRAMP. Folks are taking their InfoSec seriously, and you need a perspective of someone who can actually read that document and understand what it says, not that, hey, we're certified. To Terence's point, by whom?
Yeah. We do have about 10 minutes or less to go, so we have a few more questions. How can a clinic with a limited budget be sure to contain costs and ensure a successful implementation?
Jawad?
Measure twice, cut once. Do your due diligence up front. Where we've seen cost overruns become exacerbated is the drip, the painful drip, right? So you have a cost that you've agreed to X amount of thousands of dollars per month. And because the scope wasn't clearly defined up front, now every time you go back and have a conversation about an unmet need, you're going to hear the three most dreaded letters in the English language, SOW. Or now as it's known as LOE, level of effort, which is, hey, you never told us about this before. Let me send you a proposal, and it's time and material, and we think it's going to take this long. And now your wonderful 90-day implementation, which through pulling and pushing became a 6-month crucible that you could live through, is now 18 months. It's different to forecast 12 months. It's altogether a different thing to forecast 12 quarters, which is sometimes where these implementations that are not well contemplated and well contracted wind up. Terence, your thoughts?
I agree with you totally, Jawad. That the main thing is scoping, scope. People often, hidden costs often come about when there are things that are out of scope and it wasn't spelled out. So that's the most common. But there are a lot of different ways to approach this contractually. I mean, in the old days, I used to always push for fixed fee. I wanted a fixed fee implementation. Now I've seen there's a pro and a con to fixed fee. The pro is that, okay, it's going to be within this budget. The con is you might get poor services or a partially done project, or you'll get shorted on training. So what I've been trying to do, if I can get some things fixed fee, fine. You always negotiate buckets of hours at discount if you're going to go over. But sometimes I do fixed fee for certain services that I think the vendor should be able to quantify, and then maybe time and materials for training or certain things, because time materials is scary, of course, but fixed fee vendors often put in a 15-20% buffer anyway. The price goes up, and then, you know, unless the scope is really perfect, you may get less than you wanted in terms of testing and training. So I do like a hybrid approach depending on the nature of the product. But the main thing is to tie a significant portion of the fees, especially the ongoing subscription fees, to acceptance. If you get that, you know, everybody, the vendors wants to get to the finish line of acceptance, and then their subscription fees kick in. And that tends to bridge the gap when there's an SOW or an out of scope type issue. That's my experience.
And I think just as a final point on that, if you're an executive director, you've cut a check for 5 figures, you're really not wanting to look back and really see whether that was 131 hours or 132. You're ultimately after an outcome. And so what sometimes tends to happen is we become so fixated on bean counting that it becomes an energy expenditure exercise. To Terence's point, there are some times where we utilized fixed fee and other times where there's variable time and material. There's strategies for both, and there's value propositions for both. As long as the vendor can demonstrate competency relative to that ask in a firm way, and you're able to align your scope, then it may be helpful to use one or the other so as to avoid the bean counting exercise that you're expending, because that's dollars and energy that you're deploying on top of the SOW.
Great. Well, it looks like we've covered the majority of our questions. Is there anything else you wanted to cover before we wrap up?
I think we've had a nice high-level description of the perils and the joys of the EHR implementation. Maybe I should have been more positive, but a good implementation makes it all worth it. There is a lot of, Jawad was more balanced. There's a lot of benefit from getting an EHR that you know fits and functions. And it increases performance, increases outcomes for your patients. You can find data when you need it. It's wonderful if it goes right. But if you have any more questions, you know, I'd be happy to ever answer questions. Or see if we could help you out in any way.
Great. Well, thank you both for wonderful information you've provided for us today. Please note Terence and Jawad's contact information on the screen should you wish to contact them. You will also be receiving a follow-up email with these same details. And like I said, all this will be available on Behavioral Health News website, and you'll receive an email with that website address. Stay tuned in the coming weeks for an invite to the next session of This Will Only Hurt a Little. And thank you all for joining us. Have a wonderful day.